Okay, thank you. Hello, it's Dr. Weiss speaking. Good afternoon. It's great to be back. The subject that I was asked to talk about today is management of stimulant side effects. I think it's a great topic, and even as I was preparing this talk after many years of treating thousands of patients with stimulant medication, I actually learned some very interesting things. So I hope you enjoy. These are my disclosures. I have consulted to pharma over many years about the development of many of the stimulants that are commonly used today. I get royalties from a book publication, and we'll be getting royalties from the publication of a measure to look at functional impairment. At this point in time, I am also working on the development of digital therapeutics for ADHD and other disorders. One of the things that I learned in preparing this talk is that a lot of this literature is very old. I worked very hard to find modern or current new studies, and whatever I found, I am going to present. But when it comes to review articles, it's quite striking that a lot of this literature goes back more than 10 years. So, for example, the European guidelines from 2011. That's more than 10 years. Same for a very highly quoted article by Johnny Graham and David Cohill. So certainly I think it is time for another review and an update that incorporates some of the new information I'm going to talk about today. The learning objectives for today's talk are first to identify and review the literature on the serious side effects or what is known about longer-term side effects. Then we're going to talk about the bread and butter of the prevalence of mild, moderate, and severe side effects as they have been identified in randomized controlled trials where you can compare adverse events against placebo. I'm going to emphasize that the importance of psychiatric side effects has really been underestimated. The major reason for discontinuation of stimulants is psychiatric side effects, and yet they have, in fact, been the least studied, with very little in terms of actual research and controlled research regarding ways in which we can manage some of these psychiatric side effects. And lastly, I'm going to share my clinical tricks over the years that I have developed that I've found to be effective in working with patients on management of common side effects. So the first thing to look at is growth. These slides are courtesy of James Waxmonsky, who has just published a very important study, one of the very few studies that's a randomized controlled trial looking at intervention for a side effect and what's effective. So we'll start with the MTA, and a lot of our understanding of management of side effects and side effects themselves comes from MTA. As you know, the MTA is one of our most important prospective, naturalistic, long-term follow-up studies with 10 assessments done over 16 years, including measurement of weight and height. Patients were divided, this is largely the work of Jim Swanson, into those who took medication consistently. So that's at least 50% of the time. So when we say consistent medication, we are actually talking about half the time, and which is not exactly consistent, it's half the time. Then the vast majority, 2/3 of individuals, are classified as inconsistent, meaning they took medications at some points in time, not other points in time, or some days and not other days. And then a full quarter of patients for whom medication use is negligible. So even though we all know stimulants are one of the most remarkably effective treatments in medicine, it is still true that only a quarter of patients are benefiting from this intervention. So let's look at what was found in the MTA. It is certainly very interesting, and I think this came as something of a surprise. If you look at the blue lines, let's start with BMI, although the differences between looking at BMI and weight are not that different. So the patients who never took medication or a negligible amount of medication are actually quite stable over time. The patients that were inconsistent showed a decrease in BMI over the first few years of the study. So when they're taking medication, early in the study, they are losing weight and their BMI is going down. But for those inconsistent patients, that loss of weight stabilizes, and you can see later in the study when they're back in the community, their weight is stabilizing. But what's most interesting, and I think came as quite the surprise, is patients who took medication consistently showed early in the study exactly the same drop in BMI, but look what happened to them as adolescents. They gained weight. So these skinny little kids gained a lot of weight later on. They had rebound weight gain, whether measured as weight or whether measured as BMI. So looking at the 16-year growth trajectories, let's look at two groups. And really the results are not that dissimilar. Children who had no previous treatment, so that's 2/3 of the sample, the children who had negligible use of medication ended up, remember that rebound growth, ended up taller than the peers. The individuals who took medication, it had no effect. Okay, they stayed the same as their peers. So inconsistent use of medication does not affect height. However, the patients who took medication consistently ended up shorter than their peers, even though they had no medication prior to the start of the study. This is much more exaggerated if you look at the third of children who were in fact medicated even prior to their starting in the MTA study. The pattern is the same, the results are just much more dramatic. So those who were medicated for a long period of time but didn't take medication during the study ended up the same as their peers. Those who took medication before the study and inconsistently in the study were slightly shorter than their peers. But the children who were medicated prior to the start of the MTA and stayed on medication consistently during the MTA actually ended up much shorter than their peers. So that weight gain, we have always thought of stimulants as weight loss drugs. And I think this is because what we do is we generalize from what we see as an adverse event to an assumption that something is always true or true for everyone. So it is quite interesting then that the reality is children with ADHD are at increased risk for obesity by adolescents. So this is the population version of what we saw in the MTA, with that compensatory weight gain that occurs in a child that's never eaten while they were on stimulants, and then for some reason in adolescence is gaining weight over and above what you would anticipate. Childhood ADHD, whether it remits or whether it persists and continues, increases the risk of obesity even after you compensate for income and even after you compensate for other mental health problems. This is the work of a meta-analysis by Cortez, and this is recent, 2018. And this is not a small effect. We are talking about 70% of adults and 40% of children. That's very important. We all know how serious obesity is in terms of morbidity to health. So understanding increase in obesity as a result of early stimulant use is not a benign side effect. This is one of the very few studies that I have found that actually does a randomized controlled trial to help us know how to manage these side effects. What James Waxmonsky did is he did a controlled trial of 230 children who were treatment naive, which is very hard to find. They were assigned to orous methylphenidate or behavioral treatment. So the assumption is that behavioral treatment, there's no drug involved, and so there is no effect on height and weight. He took the children where the BMI was less than 0.5 Z units and ran, so these are the children that are having the problem. And he randomized them to caloric supplement or alternatively to only getting medication during school days. So they came off medication on the weekends. The risk of weight loss is greater for children who have the problem to start with. So if you have a child in your practice who's thin, who is not eating, who has lost his appetite, and is taking more medication on more days, that's the child where you're going to need to worry. The result of the study was everything worked. Giving extra calories helps. Not taking medication on the weekend helps. But just following it, just the intervention of monitoring it helps with improvement in weight. And has none of these things had any effect on height. So in conclusion, calories and drug holidays help with weight loss, but not with growth. That is a significant amount of growth. Now, I'm not sure how much functional impairment there is from ending up 1 inch shorter. I don't even reach 5 feet, and I've never had any functional impairment from being small. So I think from the parent's point of view, the issue here is not actually the height. I don't think parents are that concerned whether their son is going to be 6 foot or 5'11" unless they're into basketball. I think the question for many mothers is, if they're not growing, is that affecting other aspects of health, such as brain development? And I don't know the answer to that question. We do know that if they're losing weight dramatically, that is going to make the height suppression worse. And we also know that weight gain doesn't help with increasing height. So weight loss makes height worse. Weight gain doesn't do you anything. Even though that weight gain, you remember, is occurring in adolescence, which is a period of peak growth. Also important is that what matters in terms of weight loss is not so much the total daily dose. What matters is the frequency of use. And summer drug holidays in this study, you have to remember this study was only 2 years. I'm not sure 2 years is enough to significantly impact height. But summer drug holidays over 2 years did not lead to an increase in height. And that's the only study I know of that actually looks at that question. Of course, we don't know when height rebounds. So there are a lot of unanswered questions there. And clinically, these are examples of the kinds of questions that really matter. So now in terms of the clinical pearls from this talk, I've given myself the luxury of saying things that are not evidence-based and just telling you what I have learned actually works. So one thing is give medication after breakfast. All you're doing there is making sure that the child has one good meal at the start of the day. And according to my nutritional counseling to parents, I give 2 good meals at the end of the day. One when stimulant has worn off, and then what I call second supper, a major meal before going to sleep. A lot of parents have a lot of myths about eating and sleep. One of them is that if you eat before bedtime, you're going to have nightmares. In fact, I find that when a parent allows a kid to eat in bed, reads them a story, if they have problems with sleep, gives them melatonin, includes a routine, and gives them something that they can munch on while they're entertained in a special time that's close to the parent, that is when you'll get rebound increase in appetite, and you can easily manage, I would say, the vast majority of weight loss with those kinds of routines. It's very important to remember that for people like me and most mothers, eating is the most entertaining thing you could imagine. I love to eat. My favorite hobby is to go to a restaurant with my husband. If you are a 9-year-old ADHD boy, stimulant or no stimulant, sitting at the table, listening to parents talk, and eating is just about as boring as it gets. So it's important to conceptualize that having a meal is an attention-demanding activity, almost as bad as homework. So anything you can do to make it less boring helps. So what I like to say is, often for ADHD families, I work to create a different set of rules. Maybe in most families, children eat at the table. In ADHD families, if you want those ADHD kids that are burning Olympic levels of calories to get sufficient caloric intake, they are going to need to graze. One trick that I have found to be effective is if you put them in front of the TV watching cartoons and you give them finger foods and you say, I'm coming in here every 10 minutes. I have given you 20 chicken McNuggets. If you have eaten 5 of them in 10 minutes, the TV stays on. If you haven't eaten any because you forgot, the TV's going off. That's really effective. Okay? You will get the kid eating chicken McNuggets while they watch TV. Now, that's important to understand. That's exactly what you don't want the obese mother doing. So take all the rules for management of obesity and turn them on their head in terms of coming up with effective strategies for weight gain in adolescent or child ADHD. The vast majority of children that are on effective doses of stimulant at lunchtime will not eat lunch. I have two strategies for managing this. Most children can go 8 hours without eating if they compensate for the loss of a full meal by having snacks and extra meals when medication has worn off late in the day. The problem, though, is some of those children will get angry when they're hungry. We have a special word for that in English. We combine the word for hunger with the word for angry, and we call it hangry. It's very common in children. I remember with my own two girls, when my oldest daughter would get hungry, she would start picking on her baby sister. And her baby sister figured out, before I did, that was related to food. And she would say to me quite desperately, "Mommy, feed Elizabeth. She's starting to torture me." And sure enough, if I gave her something to eat, Elizabeth was fine. So it's really helpful if you can do something so that you just bring that real dip in blood sugar in the middle of the day up a little bit. You won't get them to eat. But stimulants do not suppress thirst. Nothing suppresses thirst. If you give them something salty, could be chips, could be peanuts. Peanuts are a full food, and something to drink. Whole milk is incredibly fattening. Chocolate milk, anything to drink, a Pediasure, a nutritional supplement. They will drink something, especially if you include in their school program that the teacher says, you can't go out to play until you drink this. Drink it. And it's it. That has fully compensated for the lack of appetite and the loss of a meal at lunchtime. So many families have very rigid rules and hold very tightly to those rules, and that requires a lot of psychoeducation and behavioral intervention. Rules like, "Mommy's tired, supper is over, the kitchen is closed. If you don't eat at the table and finish all on your plate, then you don't get anything afterwards. Don't eat sugar. Only eat healthy things." These are great rules for the mother. They're not good rules for a child that is emaciated and now is at the first percentile in terms of weight. The perception, at least in North America, that sugar causes ADHD, despite multiple studies showing that that is not the case, is almost ubiquitous. But if you eliminate all sugar from the diet of an ADHD child, then you are, in fact, eliminating a significant potential source of calories. In addition, for my patients, I like to recommend a multivitamin with minerals such as iron and zinc. Iron and zinc, as you know, are the cofactors that facilitate the production of dopamine and melatonin, and a very significant proportion of children have low ferritin. This is not only prophylactic of that nutritional deficiency that directly impacts the disease, What's also important is it allows parents to relax about nutrition. The nutritional reality is you do not need a huge amount of protein to get your necessary requirements. You do not need to have a quarter chicken or a steak. An egg is giving you sufficient protein. So allowing parents to relax, knowing that their kids have sufficient protein, vitamins, and minerals means that they're going to allow their kids to correct what is the most prominent nutritional deficiency, which is weight loss. Calories, simple calories. I would also comment in the review of the literature that I did for this talk. I did not find a single article on how to nutritionally nourish a child on stimulants. So this is a very unique nutritional situation for which we have very little information. We need a study like Waxmonsky did, giving us guidance that we can share with parents about what to expect from a nutritionist's point of view for management of nutrition in this situation. So I'm going to turn now to the issue of cardiac side effects, which I would describe, unfortunately, I just described areas of enormous clinical importance that have received no research. There is a great deal of research on the cardiac implications of stimulants, which may be important since cardiac side effects would be serious, but it has turned out to be something of a tempest in a teapot in the sense that we have not shown there to be significant cardiac concerns. So there are potentially insignificant increases in heart rate and diastolic and systolic blood pressure. You're talking about 1 beat per minute. Now, I can't say that an increase of 1 point per minute for a child that takes stimulants over 20 years is insignificant because we have no idea. Or 1 milligram of mercury. But I suspect in the grand scheme of things, it's probably not a huge issue. And in general, the consensus is that this is statistically significant and clinically not relevant, except for the outliers. So if I have a child and I measure their pulse, and that child has not an increase in 1 beat per minute, but is very tachycardic, that's the child that I'm going to be concerned about. Sometimes children will complain, my heart is beating funny, or it feels like my heart is jumping out of my chest. That's an uncomfortable feeling and deserves careful monitoring and evaluation, including an EKG. So what you're talking about in summation at this point in time are rare population level serious side effects. This has been looked at by the Food and Drug Administration, who do not recommend routine ECG monitoring. They concluded that sudden death with stimulants is lower than the national rate, and so there is no black box warning. What you do have to do, however, is you do have to screen for underlying family history of cardiovascular disease. 99% of the time, if you simply say, is there any history of heart disease? What you're going to hear is, yes, my great uncle had a heart attack. So what's a little bit more difficult is screening for the things that you really want to know about, which is usually congenital heart disease. Is there a hypertrophic disease? Are there other congenital heart problems which might put the patient at risk? In a retrospective review in a pediatric ADHD clinic, they looked at children who had been on stimulant, reasonable doses of methylphenidate for 3 years, had higher baseline BMIs, and those were the children at risk for systolic blood pressure concerns. A weaker correlation for diastolic blood pressure. That is very consistent with my clinical experience. Where I work right now, at least a quarter of children, I think, in the United States have obesity. But where I work, which is an underprivileged population, obesity is very high. And I have learned in that population, measurement of blood pressure is extremely important because those are the patients who already have hypertension. I've also learned from clinical experience that the way you measure blood pressure is using age and gender norms. So blood pressure that doesn't seem that bad to you from your general experience of blood pressure, if you are using the tables, will put the child at the 99th percentile. My electronic medical record does that for me. That's the child that I need to worry about, especially if that child is on stimulant during the day, leading to appetite suppression, and a drug like mirtazapine or risperidone at night, leading to rebound appetite, which is the perfect recipe for obesity. There is no effect of age, gender, comorbidity, or the type of stimulant or the dose of stimulant in terms of those effects. A minority of stimulant-treated subjects, if something's wrong and you do an EKG, it's going to come back with some kind of abnormality. It's going to come back with a bundle branch block, ectopic beats. Those are not necessarily serious concerns, nor are they necessarily related to the stimulant. But what I have found to be extremely important clinically is to have a handy cardiologist in your pocket, because I don't want to make that judgment call. So those are the kids, and there's not a lot of them. Those are the children that I want clearance by cardiology that whatever was there is not a concern. A wide range of, you're talking about 1 to 20% of children, and most of those abnormalities are not going to be associated with adverse events, and they're not going to be related to stimulants. But when they occur, you do want to evaluate them. Especially when they are associated with children who say that they've got rapid heartbeat, or they're short of breath, or there's some kind of fainting spell. When I worked in the far south in the United States, in the deep south, where it's 115 degrees in the summer, and the coaches are having the football team exercising without adequate hydration or chance to cool off, we often saw significant episodes. And again, I like to refer to cardiology where that's a concern. So in summary, for the vast majority of patients, all of this fantastic research, and I'm glad that we did it, is not going to be a contraindication at the end of the day to use of stimulant medication. And the most significant concern is going to be cardiomyopathy, congenital heart disease, hypertension, ventricular tachycardia, or frequent and complex PVCs. One of the things that you can think about is most of the kids that I see are being seen for well child visits in pediatrics, and pediatrics is doing a great job of monitoring height, weight, blood pressure. But when you are working in person, you have to remember, after 25 years of measuring height, weight, blood pressure, and pulse on every single visit of every single child, during my online work for the last 2 years, I stopped doing that completely because we weren't seeing our patients live. And I had to ask myself, did it have any impact? There were no clinical significant outcomes from my failure to do those measurements. I'm not saying don't do it. It was just a very serious concern to me, and it didn't actually affect a single one of my patients. Nonetheless, if you engage in those measurements and follow and provide guidance on all of these things, obesity, nutrition, growth, you are performing a very good public health service, and your ADHD kids are lucky to have the increased contact of associating with you to get that extra support for management of those difficulties that most children wouldn't otherwise have. I would also add that there's a very large number of kids that have ADHD and diabetes, and management of sugar in children on stimulants is complex, especially when the child is oppositional and uses the diabetes as a tool to being oppositional. That is a very unique and important patient group. And just like I've said, we need to work with cardiology. In that case, I like to work closely with endocrinology. Another important factor with ADHD, especially in adolescents, are the children that are using caffeine drinks, some of which are loaded with massive doses of caffeine. Caffeine does not improve attention, but it very seriously complicates through drug interaction the cardiovascular side effects of the stimulants, and therefore is not a good thing. The other thing I would emphasize is that well-regulated ADHD improves CVS outcomes. And sometimes this is paradoxical. So, for example, I was once doing a study in adults, and I had a man who was slightly hypertensive, slightly obese. I wasn't sure he should be on stimulants. He got into the study nonetheless, and ironically, once his ADHD was treated and he had better control of his impulses, he took care of himself, his sleep improved, his weight went down, everything got better. Another issue here is, we use the word hypertension. There are people with ADHD who have emotional outbursts. Have you ever been in the position of taking someone's blood pressure while they have a rage attack? So I was once in that situation, taking the blood pressure, provoked the kid unwittingly, not on purpose, and the blood pressure soared to a systolic of 200. And I went, youch! Every time this individual is having a rage attack, his systolic blood pressure is going through the roof. Again, that's a clinical observation, but when you control that hypertense and hypertension, you are doing something that's very important. It's also important to understand that ADHD, not the stimulants, the ADHD has a significant effect on cardiovascular risk. This is one of those amazing studies done in Scandinavia, those population studies at which Scandinavia has done so much for our field. After a mean of 12 years, 38% of the ADHD individuals versus 24% of those who did not have ADHD had at least one diagnosis of cardiovascular disease. And that wasn't mediated by medication. It wasn't mediated by cardiovascular history. The risk does decrease if you control for all the other consequences of ADHD that we know increase cardiovascular risk. The fact that they're obese, that they have lipid problems, that they don't sleep, that they smoke, but not completely. So the developmental factors that cause ADHD are in themselves potentially associated with cardiovascular difficulty. And that Scandinavian result this year was replicated in the US population. So again, I'm going to go to my own clinical pearls. In terms of looking at where blood pressure has really mattered, I don't think you're using alpha agonists such as clonidine and guanfacine in the United States, but the hypotension or the rebound hypertension after discontinuation and restarting of the alpha agonist has been a much more significant clinical issue than any problems with blood pressure associated with stimulants. And as I mentioned, when lifestyle improves, that has a more significant impact on obesity and hypertension than anything associated with the stimulants. Work collaboratively with pediatrics, with cardiology, with endocrinology, especially if, like me, you're working in a telehealth situation where you don't have the opportunity for hands-on. And lastly, I would say that in today's world, self-monitoring has become a completely different ballgame. So the launch of blood pressure cuffs where patients can monitor themselves is extremely helpful. It gets rid of the white coat effect. Adolescents with ADHD are extremely sensitive, more sensitive to the white coat effect. And many of the apps that are associated with do-it-yourself blood pressure monitors include the opportunity to send graphical results to the physician with no white coat effect for morning, evening, weekly trends, monthly trends, all kinds of data that was never previously available to us. I'm next going to talk about sleep, and I don't know how many people were present at my talk yesterday. I will go through this relatively quickly, highlighting the main points, since I have sent the slides and also a recording of the talk yesterday. So if you want to know more about it, it was dealt with comprehensively in my talk on sleep and ADHD. What we know basically is insomnia is a side effect in children with ADHD. If you look at all the drugs and all the age groups, it's about a quarter of children that will have problems initially in treatment with falling asleep or staying asleep on stimulant medication. The children who weren't sleeping in the first place are, of course, going to be the most vulnerable. What's really important is I think that there's a myth out there that you only have to ask about falling asleep. But we actually know that the difficulty with sleep is not just with falling asleep. It's middle insomnia, waking early in the morning, falling asleep too late, decreased total sleep time, and irregularity in the schedule. Unlike almost every side effect where amphetamine has more side effects than methylphenidate, this is not true for sleep. It's also possible that some children benefit from low-dose stimulant late in the day. So the original recommendation was that the earlier you stop stimulant, the better the sleep is going to be. That's only true if you are stopping stimulants so early that you're completely avoiding rebound. If stimulant is wearing off at 6:30 in the evening and the child is being put to bed at 7:30, 8 o'clock, and is irritable, hyper-aroused, reactive because of decrease in the stimulant, that is probably one of the states most inconsistent with falling asleep. Meta-analysis of sleep adverse events with methylphenidate on looking at 5,000 children showed that sleep side effects will vary depending on dose optimization or forced titration. Dose optimization, when you find the dose that is best for the child and follow them over time, insomnia is actually not that often an issue. The other thing is, since 3/4 of children and adults at least are coming to you with sleep problems in the first place, if you don't measure the sleep before you start the stimulant, and then after you start the stimulant, you ask about sleep, you don't know anything. Because the chances are the sleep problem that they're going to describe to you was there before you ever started the stimulant. This is a study by Craig Sermon in adults, and he looked at all the stimulant drugs and found that actually there was a lot of evidence, which has now been confirmed in study after study, that although 1/4 of children have sleep insomnia as an adverse event, in reality, the majority of kids or adults are showing improvement. And that's not just by subjective reports, it's also by actigraphy and polysomnograms. So when you read the pivotal trials for drugs like lisdexamfetamine or mixed amphetamine salts, they're showing consistently in both double-blind and open label that there's no change in sleep. And that's because they're looking at sleep as an outcome in its own right in the whole group of children, rather than just sleep as an adverse event. So bottom line, the studies are now showing that sleep as an outcome improves. There is an editorial about this that's going to come out in one of the forthcoming issues of the Journal of the American Academy, written by Mark Stein and myself. And this improvement is across the board in all the subscales that are measured by the Pittsburgh Sleep Questionnaire. So I'm going to illustrate this in adolescents and adults, and it's the same curve. You can see that the patients who were adolescents came in with sleep problems. At the end of double blind, compared to placebo, their sleep improved, and it continued to improve over 6 months, improved to the point where it normalized to be below the threshold for the cutoff for sleep disorders on the scale. More patients went from being bad sleepers to good sleepers than the other way around. And we showed exactly the same thing, perfect data on adults. So here you can see again, adults aren't sleeping. The cutoff for this scale is 5, and the adults are coming in on this 16-hour methylphenidate product with a score of 8, but looked at over time, looked at over 6 months, they are normalizing to just above 5, and they're staying there. So sleep got better for most patients most of the time, and over time. So when we prescribe stimulants, we should not increase the nocebo effect. Don't say, this medicine is bad for your sleep. This child has sleep problems to start with. What you should say is there's a chance at the beginning your child may experience some changes in sleep, but overall, for most children, over the long haul, some of the problems you've seen with sleep are likely to improve. And if your child is not sleeping before we started stimulants, the chances are greater than not that he's going to be going from being a poor sleeper to a good sleeper. So in terms of the sleep data, this has led us to completely question our assumptions. A lot of what I learned 10 years ago is wrong. You have to measure sleep if you're going to measure ADHD. It's a 24-hour disorder, so you have to have a baseline or you don't know anything. Sleep duration and stimulant duration have a complex relationship. A little bit of stimulant late in the day may be helpful. Although insomnia is a common side effect, it doesn't tell you about sleep for the group as a whole. And most of all, we have lots of evidence now that when ADHD gets better, sleep gets better. And if you treat the sleep disorder, the ADHD also gets better. So let's look at the side effects we are dealing with every day. The multimodal study of ADHD, the MTA, one of our most famous studies, showed that about 1 in 10 of our patients are stopping medication because of side effects. But interestingly, and I think this is my take-home point, we have focused on all the physical side effects and we haven't focused on the psychiatric side effects. Most of those discontinuations are for psychiatric reasons. About half the side effects were mild, 10% were moderate, and only a very small percent were severe. So very safe drugs. The rate of discontinuation can vary. Some of the studies, it's as low as 2%. The highest is 10%. In general, the chances that your child will go off stimulant because of a side effect is small. The exception being psychiatric side effects. And in this area, if you see psychiatric side effects, it's very important to remember Efron's incredibly important study showing that amphetamines have a higher rate of psychiatric side effects, crying, anxiety, sad, irritable, nightmares than the methylphenidate products. So the number needed to harm is about 4 or 9. And this is a study by Shacker showing when he did a randomized control study of adverse events, that 4 out of the 5 patients that discontinued, it was because of behavioral withdrawal. Meaning, in the words of one of my young girls that I treat, Dr. Weiss, I was much too bubbly, but now I am not bubbly enough. Teachers love a dead child, a quiet child, a child that never makes problems. Parents don't. They want to see their child alive. And parents will discontinue medication and live with the ADHD if they feel that you have zombied their child, made their child flat. So looking at this, we talked about all those somatic side effects. The psychiatric side effects include that blunting, restlessness. In toddlers, I've seen paradoxical increase in hyperactivity. Crankiness, rebound is a huge problem for parents. Better at school and a nightmare at home. That has to be treated. Sadness, and sometimes, rarely, even paranoia, subtle paranoia that's important to evaluate because it has a big impact, and perseveration. Kids that went from flying from one thing to another to a state of being so hyper-focused they can't manage transitions. Headaches are more common in ADHD. My experience with stimulant headaches is they're often flash headaches. I usually say to parents, and this is not evidence-based, just a clinical experience, before you go and run for the Tylenol, wait 5 minutes. The headaches tend to present as a slight achiness, and if you hydrate the child or feed the child or entertain the child, very often it's as effective as the Tylenol itself. Just like every other side effect, if it was there before you started, and headaches are common, the pooled prevalence of headaches in children was 26%, those are the children that are going to have problems with headache after stimulant treatment. So the odds ratio of having headache if you have ADHD is double. The odds ratio of headache associated with stimulant medication is actually pretty low, barely greater than 1. Stomachache is another common complaint. And the best treatment for stomachache is taking the medication on a full stomach. Again, this is usually a short-term side effect, and it makes a huge difference if the child eats breakfast. So anything you can do to improve breakfast, including making sure to give the medication after the child eats, will have an effect. Since some children where I work get their medication at school, it's really important if they're eating breakfast at school that they take the medication after the school breakfast. Seizures are very interesting, and this is another area where in the last 10 years we've learned a lot. So what we have learned, cutting straight to the chase, is a lot of children with epilepsy have ADHD and benefit profoundly from stimulant treatment. They are just as responsive as children without epilepsy. And the bulk of the literature shows that stimulants do not lower the seizure threshold. Nonetheless, the better part of wisdom is where you have a child with seizures, I do an EEG prior to stimulant and after stimulant, partly because I don't extrapolate group data to individuals. And so I want to catch that one child where it might get worse. I've done this a lot, and I will tell you that I have almost never seen a worsening in seizures. I've almost always seen an improvement in ADHD, which can manifest as compliance with anti-epileptic medication. But the knowledge for me and the parent that the stimulant has not worsened the seizures is very important. This is a massive study, one of our amazing studies, and it looked at, it's a network meta-analysis. That means it's a meta-analysis of a meta-analysis. Only Sam Cortez could do such a study. And he looked at, you're looking at over 10,000 children and 8,000 adults. He looked at the time point closest to 12 weeks. He found all drugs were better than placebo. And the amphetamines had a large effect size, and the methylphenidate overall had a moderate effect size. But amphetamine was less well tolerated, and there were very few drug-to-drug differences. This is a forest plot, and you can see looking at dropouts. On the left are the children, And the forest plot shows you over here the drugs and the adverse events most likely to lead to dropout. You don't use, I don't know if you use clonidine or guanfacine in Turkey, but actually it's not the stimulants that have the most side effects. It's the alpha agonists, and yet we think those are the gentle drugs and tend to start with them for preschoolers. But overall, you can see that the drugs are lining up pretty well in terms of dropouts, with the exception that there's lower tolerability for the amphetamines, which is what led from this study to the recommendation that the drug of first choice in children was methylphenidate. And you can see the similar results in adults, except that the discrepancy between methylphenidate and amphetamine is less obvious, which led to the recommendation that the drug of first choice in adults to start with are the amphetamines. So let's look at my pet peeve, the psychiatric side effects. In terms of suicide, there was a major study in 2017 that showed that ADHD, no surprise, is a risk factor for suicide. 8% versus 1%. But the therapeutic use of stimulants as a risk factor was much less clear. In a population database in Hong Kong, in individuals treated with methylphenidate, the relative incidence of suicide attempt during periods where patients were on methylphenidate versus off methylphenidate was not significant. They looked at increased risk. In the 3 months before you start stimulant, there's an increased risk of suicide. In the 3 months after you start stimulant, there's an increase in suicide. That's no surprise because somebody brought that child for treatment. Something was wrong. But there was no difference at all in the 3 months before and the 3 months after. And the risk returned to baseline with ongoing treatment. So there is no causal association between methylphenidate and suicide attempts. Toxicity from stimulant overdose, where it does occur, is actually quite low. For tic disorders, you know that there's a very strong comorbidity. Children with ADHD are likely to tic, and children with tic disorders, half of them, are going to have problems with ADHD. But overall, in group data, we do not see that stimulants increase tics. Nor do we see that lowering the dose, increasing the dose, stopping the medication has any impact on the tics. That being said, this is group data. And I have certainly seen children where I started the stimulant and they started ticking like crazy. And I don't ignore it. No matter what happens in research, I treat the patient. I don't always treat the research based on group data. Looking at tolerability of methylphenidate in treatment-naive children with ADHD, this study that came out in Pediatric Drugs this year is the best study because it's a naturalistic, real-world study. They looked at medical records of 480 treatment-naive children and adolescents with ADHD and found 11 that stopped treatment. And the reasons included irritability, tics. Again, psychiatric side effects are the main reason for discontinuation and rebound. And you can see that most of these side effects in naturalistic studies, you're talking about 1 in 10 of your patients. The effects of stimulant dose and the dosing strategy on treatment outcome is also quite interesting. And in a systematic review, again, of over 7,000 children, we found out what we already know. If you go high enough, the efficacy gets better. and the side effects get worse. What's really important here is that the incremental benefits for most children, when you go beyond 30 milligrams of methylphenidate, or the best dose for that child, are not huge. So for all of our patients, we're trying to balance the side effects against the benefit that we see. That's really the art of clinical practice. There are specific studies of emotionality, and this one looks at children who had or didn't have irritability. And what they found was 28% of the children were irritable before starting their medication, but their emotional side effects decreased with medication. So there's a whole group of children out there who will get irritable, but for group data, most of them will get better. And the baseline anxiety and depression were significant in predicting those side effects, but anxiety, sadness, and irritability often improved. I've talked again and again about rebound, and I would say I spend a significant amount of time looking at rebound, and behavioral management of rebound involves a lot of psychoeducation. You can treat it with a small dose of stimulant that eliminates the problem by changing the pharmacokinetics, so instead of going down, it wears off slowly. But actually, rebound is a state that is not the same as ADHD. It's reactive. It's kids that explode when you say something benign to them. And so one of the potential treatments for rebound is just leaving the child alone until it resolves. Children don't see their own irritability and rebound, and I always find that quite interesting. We know very little about the management of dysphoria. I did not find a single publication like Slomski's publication on management strategies for dealing with growth. I didn't find anything on how to deal with dysphoria. Sometimes I lower the dose, sometimes I add an SSRI, sometimes I do psychotherapy, but this is the reason that I will stop stimulants, because most parents will prefer an ADHD child to a blunted, miserable, unhappy child. A happy child is the cornerstone of what you want children and their life experience to be. So this is something that is not always easy to manage. Never a teacher complained, often a parent complained, and not something the child themselves is always aware of. So in conclusion, most stimulant side effects are manageable. The vast majority of research is now quite conclusive in looking at weight, height, and cardiovascular effects, which in fact I think are clinically quite benign. And the most difficult side effects likely to lead to discontinuation are those that are psychiatric side effects, especially for those who are vulnerable to psychiatric problems in the first place, and little, if any, research has been done on how to manage those strategies. Thank you.